And thank you for coming. This webinar series from the Eye and Ear Foundation is called Sight and Sound Bites. This is a bi-weekly webinar series, but we highlight the research at the University of Pittsburgh School of Medicine for these areas that we're going to be hearing about today. Today's topic is corneal transplant from donor to recipient. And I'm Lawton Snyder, the CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Eye and Ear Foundation to support research are really only made possible because of philanthropic support. We greatly appreciate everybody who's been supporting the Eye and Ear Foundation. We know many of you who join our webinars are, and we appreciate everybody that's joining us today. And if you have any questions about how to support the Eye and Ear Foundation, you can always reach Mr. Craig Smith, whose information's in your email. So some housekeeping things for today. This is Zoom. You kind of recognize it. It's a Zoom webinar. But since it's a webinar, we can change a few things. We disable chat because it gets distracting. We're going to use the question and answer function only. So, but we want to point that out because we really want you to ask questions. So if you have a question at any time in the program, you can type it into Q&A. Just click on Q&A and type in your question. All questions will be saved to the end, but I'll read the questions to our panelists, and I think you'll again appreciate the topics that we're going to be discussing today. Refrain, if you will, from very personal health questions if it's something that you know is only going to pertain to you and because of something that you have going on with your health. We'll ask that you maybe submit that to Mr. Smith rather than the audience, because we'll, that may not be of interest to everybody. And then please feel free to use the subtitle function in the closed captioning below. We want to make sure that we point that out and let you know that it is available with our webinars. And then we will let you know you will be added to our list for future webinars, and you can always unsubscribe if that's your preference. So our two speakers today, Dr. Roheena Kamyar and Janice Anderson. Dr. Kamyar is a clinical assistant professor of ophthalmology at the University of Pittsburgh School of Medicine. And Janice Anderson is an ocular customer service specialist with the Center for Organ Recovery and Education, or CORE, for the Eye Bank. So we are going to start with Janice Anderson, and we welcome you, Janice, as a guest to our program. But we work very closely with CORE, or our physicians and our surgeons certainly do. And we're really happy to have you share with us the things that are happening in CORE from the side of the donor providing organs for corneal transplant. So thank you very much. We'll get started.
Okie doke. Okay. So this is one of my favorite little guys. He's Rockland, but he is a cornea recipient and starts our program. CORE's mission is to save and heal lives through donation. And the vision is that every potential donor will make a pledge for life. Our values include compassion, education, innovation, integrity, life support, respect, and responsiveness. CORE is an organ procurement organization, and we're one of 57 OPOs in the United States, which is federally regulated and not-for-profit. And what makes also CORE unique is that there is an eye bank as part of its organization. And besides life-saving organs, solid organs such as heart, lungs, liver, and kidneys, we also coordinate the recovery of tissues such as tendons, heart valves, veins, skin, bones, and corneas. And that's what I'm here to talk to you about today is the corneas. Some cornea criteria that you might find interesting is some of the inclusions are that we can recover and consider corneas from donors ages 2 to 75 for transplant. If a patient has had cataract surgery, glaucoma, a history of LASIK surgery for correction, these are all okay, and we can still consider those corneas for transplant. If a donor wears glasses or contact lenses, or even has a diagnosis of cancer, those are all okay for us to consider the corneas for transplant use. Some exclusions are some neurological conditions such as dementia, Alzheimer's, and rabies actually affects the brain. And anybody who has active rabies at the time of their death, unfortunately, is excluded. Also behaviors, IV drug use, male homosexuality, and incarceration in the 12 months preceding a death can also exclude a donor. The cornea, as we all know, is the outermost part of our eye, and it's referred to often as the window of the eye. When light comes in through the cornea, okay, then the inside parts of our eye work properly, and it allows then the retina and the ganglion cells and rods and cones and sends the message to the brain so we can see. When there's a disruption in this process at the start with the cornea, and the cornea is cloudy or scarred, then it affects how the rest of the eye works. And our vision is impaired, sort of like your image in a shower and your bathroom mirror after a shower, or trying to look through glass block and see what's on the other side of that. I really like history, and there's really two important players, at least to be aware of, if not for no other reason. The first is Edward Zerm, and Edward Zerm was an ophthalmologist in Eastern Europe and had a huge clinic. He is credited with the first successful cornea transplant in 1905. And from that surgery, cornea transplantation became recognized as a viable treatment for those patients who were blind as a result of cornea blindness and cornea scarring and diseases. The other gentleman is a doctor in New York City, R. Townley Patton, in 1932, and he is credited with establishing the first eye bank. What he found himself doing to have corneas is to go to Sing Sing prison and obtain corneas, got authorization from those prisoners on death row that at the time of their execution, their eyes could be donated so that the corneas could be transplanted. He and another woman in New York City decided that everybody should be able to have the possibility of donation and donating their eyes so that corneas can be transplanted. And so the concept of this eye bank was formed. And by 1944, the Eye Bank for Sight Restoration in New York opened its doors. And within a decade, there was numerous eye banks across the country, including the beginning of CORE. CORE started as the Pittsburgh Eye Bank in 1952. It was part of the Department of Ophthalmology at the then Eye and Ear Hospital of Pittsburgh. In 1980, the Pittsburgh Eye Bank incorporated as a nonprofit organization in the state of Pennsylvania. And in 1996, the Medical Eye Bank of Western Pennsylvania and CORE merged, and the CORE Eye Bank began functioning. And in 2017, we did dedicate our eye bank in the memory of Robert Arfa, who was our medical director, not only for the CORE Eye Bank, but also for the Medical Eye Bank of Western Pennsylvania. And he was tragically killed in a plane accident. So the cornea recovery from our donors is a sterile procedure. We generally remove only the cornea with a band of the sclera. The donor is draped. The surgical instrumentation is sterile. We wear sterile sleeves and sterile gloves. And like I mentioned earlier, the cornea is like a window. The scleral rim, the white rim, is kind of like the window frame or the corneal frame. It supports the cornea in the storage media, until surgery. The cross-section of the cornea is really interesting. It's fairly complex because there's several layers to it. And if you think of about 2 business cards on top of each other, that's the approximate thickness of the cornea. And in those 2 business cards of thickness, there's 3 layers and 2 membranes. The surface of the cornea is epithelium, and it's exactly like the epithelium of our skin. It's constantly regenerating and renewing itself. And as our tears and our blinking wash away the dead cells on the surface, and new ones are popping up. And so it's a nice, smooth, clear layer of cells. There's a membrane they're attached to called Bowman's. And then the center of the cornea, which comprises of the vast majority of the thickness, is the stroma. And then there's one single membrane at the bottom called desime, and a single cell layer called endothelium at the very bottom of the cornea. And the endothelial cells are different from the epithelial cells on the surface in that they do not regenerate. And so these cells gradually decrease in numbers throughout our lifetime, and they also can change shape depending upon how the cells have kind of fallen out throughout our lives or changed and have moved around to cover up those empty spaces. So we look at the corneas with a slit lamp, and the slit lamp's exactly the same instrument your doctor uses when you go in for an eye exam, and you're on one side and they're on the other. And so we look at the corneas with this slit lamp, and we can see and observe defects that are maybe on the surface of the cornea, okay, or in the inside of the cornea, and changes that might occur with the cornea after a donor's death. We can also see abrasions, like scratches on the cornea, or foreign bodies that might be embedded. We kind of see those sometimes with car accidents, and also in like edema building up in the stroma, and some folding and infections that might have started. So a slit lamp is basically a circle of light, and we narrow it into a beam or a slit. And in that slit, we can see the different layers of the cornea. And you can see that in the variation of light in this photograph. The epithelium is on the outside. It's nice and smooth. The middle of it, which is a little grayer, that's the stroma. And you can just to look at it, it looks even, it looks compact, doesn't look, kind of abnormal. And on the far left-hand side then is just a small reflection of the endothelial cells. And this is another example. And even without training, I think all of you could recognize that there's something very wrong here. And those are scars, okay, foreign body scars that were in this particular cornea. And what this allows us to do is to be able to know what type of transplant each cornea is best suited for. And we can also see infections that can develop sometimes with some of our donors when they're in the hospital. And we can also see previous eye surgery. And this is a surgery called radial keratotomy, which is not done anymore, thank goodness. It was the precursor to LASIK. But we're able to see and detect these types of surgeries with our slit lamp. But what we can't really see too well is the endothelial cells, that single cell layer on the bottom of the cornea. And even though the cornea is clear and it looks healthy, the cells could look like this, which is very normal and what we like to see, but they could also look like this. And this is actually the beginning of a disease process in the cornea. And while the cornea is still clear, it won't stay clear for very long as this disease process continues to envelop these cells. So to look at these cells, we need a special high mag microscope called a specular microscope. And with this, again, we can see that's the normal cells, and they're even in size and shape, and they're close together and compact. And so we know that the density of these cells is going to be pretty high. And then we have this low density, and these are cells, they're even pretty much, they're really uniform in their sizes and their shapes, but they're really large, especially compared to what should be as normal. And so this density is really low and really will not be successful if that particular cornea is used for transplant, because there's just really not enough cells for a transplant surgery. And then this is a disease process called guttata. And for lack of a better kind of description, I kind of liken it to a lump that develops on the membrane that the endothelial cells are attached to, and this lump pushes through and kind of destroys the endothelial cells that are there. And because it's a lump, the surrounding cells can't migrate over top of it. And so that absence of cells remains. And these little lumps or guttae kind of keep developing throughout the whole cornea, so that the overall density continues to decrease and decrease. And as that happens, then the cornea takes on some symptoms that are recognizable, and vision is gradually lost, actually. So the traditional transplant for almost 100 years, it was a full thickness transplant, top to bottom. The surgeon would punch out a 7-8 millimeter disc of donor cornea and transplant it into their patient. And that was pretty much how it went for almost 100 years. But in 2006, 2005, maybe, I came back to core in 2006. And just prior to that, in 2005, endothelial keratoplasty, okay, and keratoplasty is a fancy word for cornea transplant, was actually starting to take off. And the endothelial keratoplasty is the transplantation of the donor endothelium, the membrane they're attached to, and a little bit of the donor stroma, that middle part of the cornea, okay? And that gets processed here at the eye bank. And it was found that approximately 80% of patients who need a cornea transplant needed because these endothelial cells are no longer functioning properly. There's either not enough of them or there's a disease that's affected them so that they no longer work. And so the surgeons have started to do more of these types of transplants. Recently, in the past 2 or 3 years, there's a new type of endothelial keratoplasty called DMEK. And DMEK is the transplantation only of the donor endothelium and the Descemet membrane. So if you're kind of thinking about those two business cards, the DMEK is approximately 10% of that bottom business card. Okay, so 90% of the cornea is not being transplanted. And with the DSEK, there's approximately 25% or 20% of that bottom business card, okay, is being transplanted. And the remaining tissue is not transplanted. So it's very thin tissue. And this is the surgical outcome. This is what, the post-operative appearance is. And so it's much different. There's not all those sutures going all the way around the eye. There's only just 2 or even 1 now, little sutures that are on the side of the eye. And so visual acuity is brought back pretty quickly for these patients. And so we process these corneas in the core eye bank. We do it in a dedicated OR. And the cornea is actually mounted on what's called an artificial anterior chamber. And it's locked into place with a helmet. That's that kind of little moon-shaped thing on the top. And it's pressurized with the cornea storage media. You can see the syringe with some pink fluid in it. That's actually been injected into the anterior chamber and kind of supports and pressurizes the cornea. We measure that pressure just to make sure that it's not too high or too low with this instrument. We remove the surface cells, the epithelium, because the epithelium is really dead cells right now. They are obviously post-mortem, they do not regenerate. So we remove those cells and we take a measurement of the total thickness of the cornea, okay, so that we know exactly how much we need to cut off. Every surgeon has different preferences about how thick a graft they would like. And so we try to, customize the graft to their specifications. So we measure the thickness and then we mark it, because ultimately once we cut it, we also need to put it back together again. So this alignment mark on the surface just helps us put the cap back into its proper position. This is the turbine with the cutting head on it. And in that little cutting head is a very small blade. And that blade is what's going to actually do the cutting across the cornea. And we mount it onto the helmet, this helmet with that little moon-shaped thing, and we pass it across. And right here, hopefully my video will work. And there we go. You're not in the dentist's office. So we pass it across the cornea like that. Maybe not. Or maybe not. And in the cutting head, you can see, okay, the small cap or this portion that we cut off. And what's left then in the artificial anterior chamber is the graft that the surgeon's going to use. We measure its diameter, and in the next slide, you can actually see the edge where it was cut. If you look at that little beveled edge on the edges, and we mark it with an S, and we stamp it. It's an orientation mark. Because this tissue is so thin, the surgeon needs to know the top from the bottom and, to position it into the patient's eye properly. We take another measurement so that we can confirm that we've got the thickness of the cornea to the specifications of our surgeon. And then we put the cap back on, which is why we did that orientation mark. So we can put it back on, and the cap is replaced and protects the graft really until surgery the next day. And then we separate it. There's a vacuum actually that's developed in this anterior chamber. So we have to break that vacuum without damaging the cornea. And so that's separated. And then the tissue is put back into the storage chamber and stored in our refrigerator until it's taken over to the surgery centers for the transplant. We also process DMEK. And DMEK requires an operating room microscope in order to accomplish this. And that is Justin, who works with me in the eye bank. And the cornea is secured on a suction block. Okay, so it's kind of held in place just from suction. And we use a guarded punch, and this guarded punch just punches partway through the cornea, but not all the way. And what that will allow us to do is to separate the Descemet membrane with the endothelial cells from the rest of the cornea. We use some trypan blue, and that actually just stains the area that was punched by the guarded punch. And you can see that ring, and that's where the cut was made from the guarded punch. Then we kind of start teasing the edges of that, where that punch was made. And this L-shaped instrument actually kind of we work around the cornea, and you can see, if you look behind that instrument, you can see it sort of opening behind it. And so that's the beginning of the separation of the Descemet membrane from the stroma that it is attached to. And we do this all the way around the cornea so that it's loosened all the way around. And once it's loosened, then we take special forceps and grasp one edge of it, and we slowly start pulling it across. And you can see this is pulled across about 50%, and you can see the stained edge, okay, of the graft on the upper left-hand side, sort of almost at 11 o'clock position. But that's the graft that's being pulled across. So that's, again, think of your business cards, about 1/10 of that bottom business card. That's approximately how thin this tissue is. And so once it's pulled across almost all the way, but not quite, we punch a small hole, or like a window, into the stroma and the front part of the cornea. And that comes into play in the next slide, because we slide then the graft back over into place so that it lays back in its natural positioning in the cornea. Then we flip the cornea over so that it's actually the epithelial side up, and that little hole or window we made is opened up, and right in that opening is the graft. And so in that little window that we created, we again put an orientation mark for the surgeon, which is an S. And again, that way, when they are in this operating room, it is very clear what side is up and which is down, because it's imperative that a graft be positioned correctly for success. Anyhow, then we close the 2 millimeter little window that we created, and this graft goes back into the storage chamber until surgery time. And so this is, Dr. Kamyar is going to talk about all the different types of transplants that are done. But again, for well over 100 years, the traditional transplant, the PKP, as well as a few anterior types of transplants, were performed, and with a lot of sutures and a lot of time healing. It takes several months for actually the eye to recover from the full thickness graft, and because of that surgical wound that needs to be created. With the DSEC and DMAC, when it is indicated for patients, visual acuity comes back much faster. It's much more stable. And there's also, even though rejection is very, very low with cornea transplants, it does still occur, but there's even less risk of cornea transplant because there's less tissue involved with the DSEC and DMAC surgeries. Not all corneas can be transplanted. Sometimes there's not enough cells that are available, like, in that image that I showed with, low density cells. And sometimes we find a medical contraindication in a donor that causes us not to be able to release those corneas for transplant. But we do support a lot of research, both locally and nationally. And some of that research includes age-related macular degeneration, diabetic retinopathy, glaucoma, and stem cell research. We also make available training corneas for the residents and fellows in ophthalmology for their training and practice surgery, and also with the development of new cornea process techniques. And so we really don't want any cornea that's donated or any tissue donated to not get used in some way or another. And so if a family does authorize the outcome of research and training for the cornea, then we do direct them into these arenas. And that is all I have for the eye bank. And if you have questions, as we were told, you can ask them in just a little bit. And I'm going to give it over to Dr. Kamyar, and she was going to fascinate you with transplantation.
All right, thank you, Janice, for that wonderful talk. So I'm going to start talking about corneal transplant surgery from the patient side. All right, so as Janice talked to you about what the cornea is, it's the clear outer layer of the eye. It helps you focus light to help see clearly, and it also protects the inside structures of the eye. It's composed of 5 different layers. And the layers that we're going to focus on are the stroma, which composes about 90% of the cornea, the descemet's membrane, and the endothelium. These endothelial cells are very important for the cornea health. So why does a patient need a corneal transplant? So it's usually done to restore vision in a person with a damaged cornea. It can also be done to relieve pain in certain situations. The most common conditions that we'll do a corneal transplant for is swelling of the cornea. There are inherited conditions, which we call dystrophies. Sometimes we'll do it for corneal scars from infection or trauma. And there's certain conditions that can cause thinning of the cornea, which will also recommend a corneal transplant. So you can see some before transplant pictures and some after in here. So these are the 5 main types of corneal transplants. We're going to talk about each one. I'm first going to talk about penetrating keratoplasty. So this is a full thickness corneal transplant. So you can see that all the layers of the cornea are transplanted. So we've been doing PKPs for over 100 years. The usual indications are for corneal scarring, as you can see in this picture here. And there's some conditions that can cause thinning of the cornea, like keratoconus. Corneal ulceration, which can be from infection, like you see here in this picture, or ulcers from non-infectious causes. And in the worst case scenario, some people will have a perforation in their cornea, which is the actual hole in the cornea. And then a penetrating keratoplasty can be very helpful for them. The benefits is that it treats all layers of the cornea. So if someone has a disease affecting the entire cornea, this procedure is the best option. The downsides of this procedure compared to other types of corneal transplants is that it has a long recovery course. So it usually takes up to a year for the vision to stabilize. And a lot of these patients will have a lot of astigmatism that require a hard contact lens to be able to see well. And there is a possibility of a transplant rejection. And this is an example of what penetrating keratoplasty might look like a couple of weeks after the surgery. So you can see there's multiple sutures there. And this is what someone might look like a couple years out from their surgery. So you can see the cornea is nice and clear centrally, and you can see the rim of where the transplant edges are. All right, so we're going to jump to the second type of corneal transplant, which we call endothelial keratoplasty. So there's 2 types, DSEC and DMEC, and we're replacing just the inner lining of the cornea in both of these procedures. The DSEC is a little bit thicker, the DMEC is thinner. So when we do this surgery, for either type of surgery, we're only removing the inner lining of the cornea from the patient. So removing descemet's membrane and endothelium. This is less than 3% of the entire cornea. And then we replace that with either a DSEC transplant or a DMEC. This procedure has been around since about 2004. It has a very specific indication. So we usually only do it for corneal edema or swelling that's due to disease of the endothelial cells. The most common condition that we'll do this for is Fuchs corneal dystrophy, which is an inherited condition. And as Janice beautifully showed us, that the donor tissues prepared at the eye bank for us. The benefits of an endothelial keratoplasty over the penetrating keratoplasty is that it has a much more rapid healing time. Usually patients are seeing well within a couple months after the surgery. There's much less astigmatism, there's less risk of rejection, and there's less suture-related problems since we don't have to put that many sutures in, usually 1 or 2. And the downside of this procedure is that the patient must lay flat after surgery. And usually this can vary from anywhere from 1 to 4 days, depending on the type of surgery and the surgeon's preferences. But this can be very difficult for some of our patient population. This is what eye might look like after having the DSEC surgery. So this would be 1 day after. So you can see the cornea is already fairly clear. You can see the edges of the transplant here. There's one suture, and here's a bubble. And this is bubble is what keeps the transplant attached to the rest of the cornea. And this is what an eye might look like a couple months after surgery. So you can see it's nice and clear. You see a very faint edge of the transplant remaining. And this is what a DMEC would look like at post-op day 1. So a nice sized bubble, and sometimes we don't even put a suture in these cases, but you can, not even see the edge of the transplant or barely make it out. And this is what the patient might look like 1 or 2 months after surgery. Great, so the next type of procedure we'll talk about is called a DALK. And so this is a deep anterior lamellar keratoplasty. It's the opposite of a DMEC. So we're actually replacing all of the cornea except for Descemet's membrane and endothelium. This has very specific conditions, very different than what we would do a DMEC or DSEC for. So this procedure has been around since the 1970s. Common indications for this procedure are corneal ectasia or thinning, such as keratoconus. This is an example of a normal eye compared to an eye with keratoconus. So the cornea gets thin and actually it starts bulging and has a cone shaped. And this, as you can see, this can obviously distort vision. And then this is an eye with granular dystrophy. And so these opacities can really obscure vision. And this is a good situation to have a DALK procedure. The benefits of doing a DALK over a penetrating keratoplasty or PKP is there's less risk of bleeding during the surgery. We believe that the wound is stronger than what you would get with a penetrating keratoplasty, and there's less risk of rejection. The downside is that it's a technically challenging surgery, and not everyone's a good candidate for this. It depends on the condition of the eye and the specific disease that we're trying to treat. So it's not always possible to do a deep anterior lamellar keratoplasty. And sometimes the patient just really needs a penetrating keratoplasty. This is what an eye might look like a couple weeks out from their DALK surgery. So it looks very similar to PKP. There's a lot of sutures in place. And this is what the eye might look like a couple years out from surgery. So you can see the rim of where the transplant is, but the center of the cornea is quite clear. And then the last procedure that we'll talk about is called a keratoprosthesis or a K-Pro. This is an artificial cornea. It still requires a donor cornea. So this red area signifies a donor cornea that was supposed to get from the eye bank. And we actually sandwich in the K-Pro, so the optic is clear, and a plastic kind of device that goes inside of that corneal transplant. So the type that we most typically use is called the Boston type 1 keratoprosthesis, and it's been around since the 1990s. There's very specific indications for this procedure. So we usually do it when someone has gone through multiple failed corneal transplants, and there's specific genetic conditions like aniridia where this procedure can be very helpful. And the other kind of situation that this works well in is in chemical injuries when a regular corneal transplant will not succeed. And so we kind of call this a last resort surgery. Benefits of a K-Pro is that it works well in many situations where other types of corneal transplants wouldn't work. And the downsides of this procedure is that there are some postoperative complications that have to be monitored, such as infection. These patients have a chance of developing glaucoma. You can get a scar tissue behind that plastic optic. These patients require really close follow-up. So we usually see these patients every 1 to 2 months to put in a contact lens to help maintain and preserve the keratoprosthesis. This is what the keratoprosthesis device looks like. So you can see here's the donor cornea that we get from the eye bank, and we punch a little hole here, and then we sandwich in that plastic optic with this back plate. This back plate has little holes, and this allows fluid from inside the eye to hydrate the corneal graft and keep it healthy. And then we have what we call a locking ring at the very bottom that keeps that device together. And this is what it looks like when we're assembling it during surgery. So here's our corneal donor tissue, and we're punching a little hole right in the center. And then we put that right over that optic. And then we put this back plate on. Here you can see it even better. And then that locking ring keeps everything together. So this is a case that I think is a good example of when a K-Pro is really helpful. So this is a gentleman that was in his mid-20s that suffered from a terrible chemical injury, became essentially blind, and he had multiple corneal transplants, but they all failed. You can see just the very faint outline of his last corneal transplant. And so with the chemical injury, it causes this aggressive blood vessel growth over the cornea that prevents that corneal transplant from staying clear. And this is what he looks like 10 years out from his keratoprosthesis. So he's been able to maintain vision of 20/50, 20/60. You know, if you can imagine, he was completely blind before he had this keratoprosthesis. And so this is a life-changing operation for patients in this type of situation. Here's a couple other examples of what the keratoprosthesis might look like after surgery. And so you can see that this cornea is quite clear, where you can actually see that back plate pretty well. All right, so what are the future directions for treatment? Stem cells really are where we're putting a lot of hope in. So there's stromal stem cells, which the Funderburg Corneal Regeneration Project, which has been funded by the Eye and Ear Foundation and was led by the late Dr. Jim Funderburg. They developed a technique which has been used in clinical trials in India for patients with corneal scarring, and we're hoping that one day we'll be able to use it here in the United States. And there's also endothelial studies that in Japan right now we're seeing promising clinical trials that injected cell therapy for Fuchs corneal dystrophy and other endothelial cell disorders that are helping regenerate the endothelial cells without the patient having to go through corneal transplant surgery. So in summary, there are several different types of corneal transplant surgery. Your surgeon will help you decide which one is the right one for you. So of all these options, usually there's one specific one that's the right one for a specific type of disease. Corneal transplant surgery is a life-changing operation. And please consider becoming an organ donor and encourage friends and family to become one too. All right, so I think I have a couple more minutes that I can show you a video. So let me just get that there. All right, so I'm going to show just one type of surgery. This is a DSEC surgery, or this is also an endothelial keratoplasty. So we see here the cloudy cornea. We're just marking where we want to put our transplant. We make a small incision. We bevel this incision to try to make it as self-sealing as possible. So we kind of angle it in a very specific way. And then we're going to use a type of hook. And this is going to help us remove the decimatous membrane. So you can see that very faint film here. So it's coming off all in one piece. And so if you can imagine, that's about 10 to 15 microns in size. And so there it is. Now we're going to prepare the donor tissue. So this has already been cut at the eye bank. And the markings are helping us differentiate where that cap of the tissue is. And so we use a punch to cut the cornea, and this helps give it clean, straight edges. And then we're going to remove that rim of the tissue, and then we're going to stain the edges with the trypan blue. So this is a blue stain that helps us see the edges better. Janice mentioned the stain does not harm the cells, and it only lasts for a short period of time. It usually dissolves completely within an hour. We use this special device. This is called an endoserter, and it kind of looks like a Slurpee spoon. It has a scoop shape, and it helps us fold that transplant with keeping the endothelial cells as healthy as possible. So this helps us to avoid damaging those inside cells. And so we wrap it up like a burrito in this endoserter. And then we're going to put the device through that incision. And then this device helps unroll that transplant slowly into the eye. And so you can kind of see the edges. They're stained a little bit blue, so it's coming out. We're shimming the device to help it unstick from the endoserter. And then when it's completely out, then we come out of the eye. And then next, we're going to put a bubble in the eye, and this is going to help that transplant stick to the cornea. We usually put just one suture, maybe two sutures in, and this is to close the incision. So this does not go through the transplant. So this is outside of the transplanted area. And then next, we're going to position our transplant. So we want to make sure that it's totally centered. And then we're going to put a larger size bubble. We're going to just, with a large bubble in there, we're going to use this rolling device. This helps squeegee out any fluid in the interface between the donor transplant and the patient's cornea. And then we just make the bubble the right size. And once we're happy with that bubble, then we stop there. All right, so that's what I had to share today. So I think we can open it up to questions.
Okay, sorry, my buttons moved. I couldn't find them. So, wow, thank you both very much. I'm going to have to say, I've seen some of these surgeries, of course, videos and so forth, but every time I'm impressed by how steady your hands are on those very fine instruments in that very small space. So it needs to be pointed out that that's pretty impressive. Thank you both. I see we have a lot of questions, and I can tell that we're going to need all the time we have to get through them. So let's go ahead and get to them. And I'm sure that I might have a few questions myself. So let's start with this. How long do corneal transplants last with appropriate care?
So on average, corneal transplants should last about 15 years. That's what they say is on average. But I have seen them last, 30, even 35 years when someone takes good care of their transplant. So that means, staying on an anti-rejection medication. So we usually have our transplant patients stay on a steroid drop once a day, and that usually helps prevent rejection long-term. So it really depends on the patient's disease also. Some conditions have a higher rate of rejection, whereas some don't. But on average, I would say about 15 years.
Okay, well, that's actually a long time. I've known people have had a much longer, but I guess it just depends, right? Mm-hmm. So now, for conditions that are, I guess this is kind of specific, but we'll go for it anyway. So with things like granular cornea dystrophy, is there anything in research that's showing that you could do surgery on that, and not have the dystrophy grow back in the new transplanted cornea?
Yeah, unfortunately, we don't really have a way of preventing the granular dystrophy from occurring in the cornea. So usually when it grows back in the corneal transplant and we see it's affecting the vision, we can repeat the transplant. So I know it's not the ideal solution. Hopefully one day we'll have something like an eye drop that could dissolve those opacities, but right now we don't. So right now our standard of care would be to repeat the transplant if needed.
Would somebody with macula off condition, which means they have, I guess, retinal detachments, et cetera, would they be a candidate for corneal transplant?
So no, so that would be a different part of the eye. So that would be the retina that's involved in a MAC off detachment. And so for that, we really rely on our retina colleagues to help with. So unfortunately, corneal transplant surgery wouldn't really help unless there was an issue with the cornea as well as the retina.
So how do you get the donor's cornea to stay on the eye? How many sutures are typically needed?
That's a great question. So I hope that video showed you that we really don't put any sutures in that donor cornea for the endothelial keratoplasty. So we put that bubble in the eye, and that's what pushes that transplant up against the patient's cornea, and that's what holds it up in place. And it usually attaches within 1 to 2 days. And that's why it's important to lay flat after the surgery. So that suture that we put in there is just to close the incision where we inserted the transplant, so not actually in the corneal transplant.
So is general anesthesia used for surgeries, or?
We usually will do general anesthesia for the full transplant, but for the partial transplants, it's usually not needed. If for some reason there's a reason that the patient wanted or needed to have general anesthesia, then we will do it. But with the partial transplants, it's usually a pretty short procedure, around an hour, hour and a half. And our patients stay comfortable during the surgery. They should not have any pain or discomfort. We numb up the eye so that it really is not necessary to do general anesthesia in most of those types of surgeries.
How long will it take to notice clearer vision for a K-Pro transplant?
That's a great question. Usually I would say our patients are seeing well. It could be anywhere from a couple weeks to a couple months. So a lot of these patients have other conditions of the eye that can limit the vision. So it depends on how well the glaucoma is controlled or if there's any retinal issues. But most of our patients, I would say within a few weeks to a couple months, they would have pretty decent vision.
Okay. And this is more of a thank you rather than a question, but we appreciate these. Just, I'm a chemical burn survivor and had my cornea damaged. Seeing the state-of-the-art solutions renews my hope in science. Thank you for your wonderful work. Well, thank you for the comment.
Very nice.
How important are the stem cells here in terms of seeing clearly? And we have stem cells around the rim of the cornea, right?
Right.
And I guess I'll ask kind of Janice the same question. Is that something when removal of donor tissue, does that come into play at all? Where those stem cells are and how those are removed?
Yeah, as a matter of fact, once it used to be that we needed actually a whole eye, but instead we can use a cornea with a wider rim. And when we recover the cornea, most often we try to remove the conjunctiva. And the conjunctiva is a thin membrane that covers the white part of our eye and the eyelids. And so in this particular instance for stem cells, we try to leave as much of that on, okay, at the rim of the cornea, because there's a lot of stem cells that are at the limbus. The limbus is the junction between the sclera and the cornea. And so by leaving the conjunctiva on, there's a lot of stem cells in that too. So when we know that that's what's needed, that's what the instructions are for our recovery staff.
And as far as the surgery, then, Dr. Kamyar, are you also paying real close attention to where the patient's existing stem cells are in terms of their recovery and making sure they have a better recovery?
Yes, absolutely. So that it becomes really important for mainly for the penetrating keratoplasty to make sure those stem cells are healthy. And that's sometimes, if they're not healthy enough, that's sometimes what sways us to do the keratoprosthesis, the artificial cornea. And so that type of procedure works really well if there's has already been damage to the stem cells.
And this is something I'm not sure all of our viewers would know about stem cells, because stem cells, people think of, embryonic or different types of stem cells. There are stem cells throughout the body. And in the eye, we have stem cells on the cornea. And that plays into what Dr. Kamyar also talked about at the end, the research that we've been supporting that's trying to use those stem cells as a way to effectively clear up a clouded cornea without having to do a transplant. So those stem cells could be very important in the future, we feel, but they are important now, even in making sure that a transplant is successful. Is that safe?
Correct.
Okay. So what kind of conditions would make a candidate with Fuchs dystrophy ideal or not ideal for cornea transplant?
So in Fuchs dystrophy, there's different grades of severity of Fuchs dystrophy. And so we usually wait till the Fuchs dystrophy is on the moderate to severe side. We pay close attention to how the vision is affected too. So a lot of patients with Fuchs dystrophy will have a lot of glare or feel like their vision is watery or steamy. And so those are the kind of things that we're looking for when we're determining if someone's a good candidate for surgery.
And I guess this is another kind of Fuchs related question. How is a transplant done in Fuchs if a cataract is also needed? What would be done first?
Yeah, that's a great question. That depends a lot on your surgeon. So some surgeons would like to do the cataract first and then wait a little while before doing the corneal transplant. And sometimes we'll do it all together. So we'll do the cataract and the corneal transplant at the same time. So it depends on the surgeon preference and the condition of the eye too. Sometimes it's a better idea to stage the procedures, and sometimes it's better for the patient to do them together.
Okay. And I see a question here that we probably, I know is not really focused on this, but I'll actually, this is about someone, and I feel horrible to hear that someone who lost their vision from a bombing in ISIS. But I'm going to have Mr. Smith follow up with you, because I think this is something that we can maybe point you in the direction of some of the other specialists that are working at the Eye Institute. I had 2 corneal transplants for Fuchs, and was amazed to watch. And so the question is, Janice, I never heard from the donor family. After writing 2 letters to different families, I was curious how many people on an average hear from their donor families.
We actually have a full department, a donor family services department at CORE, who coordinates a lot of the communication between the donor and the recipients. And it's kind of a two-way street. So all of the cornea donors, the cornea recipients, I should say, receive a packet of information and it kind of instructions with a card and even a stamped envelope to encourage them to write a note to their donor family and to, regarding their cornea transplant. And there are actually a number of cornea transplant patients who do this. The cards are sent back to CORE, and then we identify which donor family it should be directed to. And so we kind of play in the middle for a little while. And sometimes it's gone to the point where they actually meet. But we do that with not only, of course, our cornea recipients, but also those with, who receive the organs as well.
Yeah, it's amazing, I'm sure, when when those connections are made, but of course it's a private matter. Not everybody want to do that. So not a question, but the work you do is amazing. This is so nice to get these compliments. So I'll read them. I'm so thankful to CORE and INEAR. So well, you're very welcome, but thank you for the comment. So if orthid transplant will work, a patient has, did I say that right? Or is that, a patient has severe glaucoma with tubes and has failed DSAC, what are the chances of a second transplant, that a second transplant will work? Second transplants are done. I guess in every case it's different, right?
Right. Yeah. Yeah. The question is why the transplant failed. So, as long as we can address that issue, there's a lot of patients that have had a failed corneal transplant and do very well with their second or possibly third transplant. But we really want to try to eliminate what caused the failure in the first place, so that we can give you a better chance of success with your subsequent transplant.
So this is interesting. After transplants, are things like falls or accidents high risk, damaging or detaching the transplant? And so I guess you wouldn't want to go back to being a boxer, right? If you were getting
Yeah,
that transplant.
that's an excellent question. So that's I kind of alluded to it a little bit with comparing the penetrating keratoplasty, the full transplant, with the deep anterior lamellar keratoplasty with the dog. So the wound is stronger with the dog. So with PKP, we do see injuries where if someone had, it has to be a pretty significant injury, like a punch directly to the eye. Or what we see a lot is nightstands, the corner of a nightstand, and someone accidentally hitting their eye in the middle of the night. But that can actually cause the corneal transplant to come off. And sometimes those can be repaired. Sometimes the patient needs a new transplant. So that does not happen as often with the dog procedure. And definitely we don't see that issue as much with the endothelial keratoplasty, because the patient's cornea essentially is intact. We're only removing that inner lining, that about 3% of the cornea. So the strength of the cornea is still maintained in those other types of transplants.
Okay, and I think that's the end of our questions. We just have some nice comments. One is, this has been educational. Thank you for your presentation. Again, you're welcome. You have a very nice audience today. Everybody's been very showing their appreciation. And I'm a core advocate, and thank you, doctors, for all you do. I'm also a Stevens-Johnson syndrome survivor that affects both badly. Thank you. And please, you're all welcome. Again, we love bringing these to you. And I think this is a really interesting topic. Janice, I'm going to thank you. This is so nice to have guests and people that we collaborate with telling us from your side what you do. I learned a lot myself today from the whole process. Obviously, I think we'll all want to put a pitch in for organ transplant, organ donation. That is something that, is a chance for someone to benefit from things that happen, that are going to happen in life. And it always works out to be a benefit to those who receive those transplants. And there's so many people waiting, and we much appreciate it. So anything else, panelists, before we sign off? Okay, well, thank you so much. Thank you both. And we will see you folks again in a couple weeks. We'll be providing another program from Sight and Sound Bites. And thank you so much for your time today. Have a great day.